that helps me, that so I know how much to talk about on certain things. So Impact, first of all, Impact is a nonprofit organization. We are based in Milwaukee. We're not too far away from State Fair Park for our offices. We are funded by primarily by United Way organizations. The United Way of Greater Milwaukee and Waukesha County is by far our very largest funder. We also receive funding from Milwaukee County government and Waukesha County government, and I'll explain more about what we're doing here in Waukesha County with the Waukesha County Department of Health and Human Services. So I'll talk to you a little bit more about that later on. So Impact, we have a mission statement. The short version is Impact's mission is to change lives for good. So what we look at ourselves as doing is being a navigator or a connector. We don't provide any direct treatment ourselves, but we work largely within the behavioral health field, so that's substance use issues, behavioral health issues. But we've really branched out over the last 20-25 years into helping people get connected to all sorts of different services. It really doesn't matter, and I'll show you some data a little bit later, but people contact us for help for a lot of different things. So I mentioned the behavioral health area, but we do a lot with connecting people to basic needs resources, so that's food and housing, clothing, all sorts of different things. Yes.
So is that just, the surrounding counties? Or is that a program only there, or is this statewide?
Yeah,
I'm sorry.
that's okay. Please don't be afraid to ask me a question at any time. That's okay.
Good question.
Yes. A little bit more about our agency. The 2-on-1 program is what I'll talk to you most about. Our long history, going back 60 years, is related to alcohol and drug abuse services. So we've long been a place where people can go to find out how to get help with a substance use disorder problem. Again, we don't provide any treatment, and what we really do is listen to the situation that a person is in. We take into account whatever resources or their own internal resources, insurance, whatever it might be that they have, and then guide them to the next step where they can get the help that they're looking for. So we have no skin in the game, so to speak. We don't have anything to gain by doing an assessment and, we keep you now, and we make money off of you. We don't do that. We really look for what's the best match for the situation a person is in. And we take into account all different sorts of things. We look at transportation. Is this a culturally appropriate place for the person? Some people want treatment that has kind of a faith-based orientation to it. Some people don't want anything to do with that. So we really try to work with the person to find the best match. That's really important for somebody being successful, is that they feel like it's a comfortable place for them to go, or a comfortable place to be when they're getting the help that they're needing for something that's very sensitive and life-changing. So it's really important to us that we be mindful of all these things when we're working with somebody. Planning and evaluation is a real technical part of what we do. So we work closely with government and nonprofit organizations, treatment providers, to make sure that they are delivering the services that they said they would. So for federal funding in particular, there's a lot of rules that go along with that, and part of it is to evaluate whether the work that you're doing is successful and it's fitting within the boundaries of what the funding was being given before. So for some things, like especially with substance abuse assistance, it can take a year, 2 years, 3 years to really realize that a positive change has been made. So we work with some residential facilities where you're working with somebody for 1, 2, 3, 4 months. So it takes a long time to really realize the benefit of getting that funding to help that person. So that's why you need somebody working with that provider along the way to make sure benchmarks are being met, that the person is getting the help that they should be getting from that provider, and if they're not, why isn't that happening? So that's part of what that department does. So I'll tell a short story. So we've been operating hotlines for a really long time, for about 50 years. So in the beginning, there was a hotline called the Underground Switchboard. So this is a hotline that was founded about in 1970. It was a grassroots hotline, meaning that the people of the community came together and decided that a special type of hotline needed to be made available. So kind of some history. Back in the 60s, there were a lot of things going on during that era. There was the Vietnam War. There was the draft. We're being drafted into the Army. They didn't have a choice. You get drafted, you're going. New drugs are coming out. So a lot of marijuana, but there was also LSD was a big drug. That was coming out on the street. There were other things, other changes going on because there was all this turmoil, and maybe, you know, if you're familiar much with the Woodstock generation, but there was a real division between older and younger generations going on during that era, partly because of all the societal changes going on. And there's always been a gap between generations, you know. Maybe you're going through this, some of you right now, where you want to separate from your parents. You don't need them as much as you used to, and that's normal. Everybody experiences that. Parents see their kids going off in a different direction, and they don't have as much control over where they're going and what they're doing. So I started actually, well, I was 10 years old in 1969, so I kind of remember a lot of things going on then, and I had two sisters that were hippies, and you know, they went to school in Madison, and you know, they participated in a lot of the protests were going on, protesting against the Vietnam War, and you know, there's a lot of other things. Free love was another thing that was going on. So this is jarring for older generations to see their kids going through all of this stuff. They were like total aliens to them, and the kids and young people at that time wanted nothing to do with that older generation that got us involved in these wars, and that are keeping us from having access to all these really fun drugs and everything like that was going on. So there was a division. It was really serious, and a really short story is one of my sisters, and I don't know if this is absolutely true or not, but one of my sisters would go to our family doctor that we go to for many years, and you know, go there for whatever it was, and then the next time Mom went in to see the doctor would say, you know, to my mom, well, you know, Ellen was here, and you know what she told me about, you know. So HIPAA didn't really exist back then, you know, and that kind of stuff happened. And so there was a lot of distrust. There was a lot of things going on then, and people, especially younger generations, wanted to get help from people in places that they felt comfortable with. They didn't want to go to the family doctor, you know, sitting in his office and not really keeping good notes and all that kind of stuff. They wanted something different. So that's how a lot of these grassroots things started, and the Underground Switchboard was one of them. So people back then, it was, again, volunteers were staffing this hotline, and a lot of the calls were related to street drugs, but also relationship issues, or they just needed a place to call and go where they could get the help that they thought they needed. Now, the other thing that was going on during that era was the deinstitutionalization of those that were chronically mentally ill. So back in this, going way back in our history, people that are chronically mentally ill were put into asylums or state hospitals, institutionalized sometimes forever. You know, if they had schizophrenia or they had some sort of diagnosis, the best thing that we could do for them is put them in a place where they'll be safe. We'll make sure they're getting fed, they're clothed, and they have a good place to sleep. And to make sure they're doing that, we're gonna make sure they have some drugs to keep them as quiet and easy to deal with as possible. So that was really thought to be inhumane and plain wrong. when they could have been treated for, managed with their symptoms and go out and maybe get a job and live a normal, regular life. But many people were kept in these institutions against their will and without any choices. So that all started to change in the late 60s and into the 70s, and a lot of these folks then were being released from these institutions and put out into the community, but they didn't have the supports that were really needed for them to manage well outside of these institutional settings. So they started calling the underground switchboard too. Some of them had mental health issues and they just needed to talk to somebody, or they needed a place to go when their symptoms were becoming unmanageable, trouble with housing and all sorts of things. So, the underground switchboard started as kind of a counterculture thing, but the rest of society started using that hotline too. And that went on for quite a long time, and I started as a volunteer with the underground switchboard in 1985. So that's when I started, and some of that was still going on. We were still talking to a lot of people about relationships and street drugs, and the other big thing going on when I started was when AIDS started. It was HIV and AIDS started right about at the time that I started, and all of a sudden we would get calls for syphilis, or not syphilis so much, but gonorrhea, VD, things like that. Those are very treatable, easy to manage, but all of a sudden we started seeing this huge spike in calls from guys that had AIDS. And you gotta think back then, they were already very isolated. The LGBT community was very, very marginalized. And now, going along with that, they had this deadly disease, and so they were even shoved further and further into the corner. So one of the only places that somebody that felt like that could call was the underground switchboard, where they had decent people that would listen to them and try to guide them to the resources in the community that could provide them help. So a lot of things started to change just during the period when I started there. The other thing that was going on too was that industrial, you've heard about the Rust Belt in Milwaukee, certainly in this area was part of the Rust Belt. So these were, in Milwaukee, there were factories, the Alice Chalmers factory in West Allis at one time in the 50s and 60s, they employed 10 to 15,000 people at this factory. And there were others in Milwaukee too that employed huge numbers of people, and they were starting to collapse. The auto industry went through some major changes because the price of gas started going up, and the auto industry didn't keep pace with smaller, more fuel efficient cars, and they started closing. Kind of to the south and the east of us in Kenosha, there was American Motors. They were the people that first made Jeeps were all made down in Kenosha in that area, northern Indiana. The company dissolved at some point in the early 90s. So all of a sudden there was a huge number of people that were unemployed, lost really good paying jobs, and they had nowhere else, very few other employment opportunities going on. So all of a sudden, underground switchboard and what became then the helpline, we started getting calls from people that were struggling with housing. They needed access to food, free clinics, other sorts of services. So things changed really rapidly especially during the 80s and certainly well into the 90s. So that's what I said was going to be a short history, that was a little longer than I want, but it kind of gives you some context of what is leading up to where we are today, which I'll talk a little bit more as I go on here. So 211 is a hotline. It's available 24 hours a day, 7 days a week. We never close for any reason. Most often you can just reach us by simply dialing 211. It works from your cell phones. You can just dial and reach us. We have a toll-free number, and that's really important because in some office telephone systems, dialing 211 doesn't work because the phone system needs to be programmed to understand what you mean when you dial 211. So it could be that you have to dial an outbound line and then 211, but it doesn't recognize that. So that's why you have a backup toll-free number. So 90+ plus percent of the US population is covered by a 211 service. All of the state of Wisconsin is covered by a 211 service. We were one of the first of the 250 211 providers in the US to be accessible via text messaging. So this is really good for people that have limited talk time minutes on their cell phone plans. So, you know, some of those, sometimes they're called government phones, you may only have 20 or 30 minutes available on talk time on those cell phone plans. And anytime we can save some of that is beneficial, so people can reach us via text messaging. It's also really good for people that are in vulnerable situations, so they might be in a waiting room at a doctor's office, they might be around somebody who isn't safe, or they just don't feel like talking. They'd much rather, a lot of people just talk across the room via text messaging. I don't know if you've ever done that before, but that happens. So trying to be as available to everybody and by whatever means is really our goal. We also have a chat portal on our website, and then we have an online resource database, which I'll show you a little bit later. We have a call center. We have 32 workstations in our call center and almost 40 staff members. It's kind of a mix of full and part-time individuals. Our peak time of call volume is kind of in the middle of the day, so starting about 8:30, 9 a.m. up until about 2:30 or so, 2:30, 3 o'clock, and then it slows down. So we really build up our staffing with a lot of part-timers kind of in that middle, very busy period of the day. We have right now a 10 Spanish-speaking staff also, and we try to have somebody that speaks directly in Spanish available from about 6 a.m. up until about 11 p.m. virtually every day. Weekends, we have a couple of gaps. And then we also have a translation service for in every language that you can take. And if the Spanish-speaking staff isn't available, they can use the translator.
Are these all volunteers or are these paid positions?
These are all paid positions now. Yep. Okay. Part of our history is we went from being all volunteers to moving into paid staff, in large part because the calls started getting really complicated, and we were asked to take on more serious types of calls. So we had to transition away from the volunteer staff to paid staff, and that happened between about 1996 and 1999.
Made it more highly trained.
Exactly. Yeah. Training a staff member right now takes about 2 to 3 months. There's a lot of things to know, and with all the different, I'll tell you a little bit more about this, with all the different types of calls that we take, it does take some time to do that. I covered that. So, the system, so 93% of the US population is served by a 2-in-1 system. The big holdouts for not having a 2-in-1 system is down in Chicago. We do not have a 2-in-1 system. So, it's weird why they don't have it, but it's Chicago. They're different in a lot of different ways. We have a full system here in the state. There's 8 different providers. There are 2 24/7 providers, us and the 2-in-1 that is based in La Crosse. All the other 2-in-1s roll their calls over to us or to La Crosse overnights and on weekends. So there's a call center in Wisconsin Rapids, and they only have 3 people working, and so they really couldn't afford to put somebody on overnight. They couldn't pay that person, plus we maybe get 2 or 3 calls from that region overnights and weekends. So it really isn't paid for them to do that. So last year we took 65% of the state's calls. That's about 150,000 calls that we took. Our system is the 10th largest in the US. So we are not the 10th most populous state in the country, but we have a very, very good, very robust 2-in-1 system compared to many other states. And Impact 2-in-1 had the 21st highest call volume last year as well. So we're considered to be a very large and very busy 2-in-1 provider.
So we're a sicker community.
I'm sorry?
So we're a sicker community.
Well, you know, in a lot of ways, we have a very high concentration of poverty, especially in Milwaukee. You know, Milwaukee has the fourth highest rate of poverty in the US and the second highest rate of poverty among kids in the US. Racine County is another very difficult area too. They have a very high rate of poverty.
Which one?
In Racine
Oh.
County.
I like it.
So here's a map that shows where all the other 2-in-1 providers are located. Just to the west here, the 2-in-1 is based at the United Way of Dane County. To the north, it's at the United Way Fox City, which is, I think, they're based in Menasha. And the yellow there on the left is based at it's Gunderson Lutheran Hospital in La Crosse. So us in La Crosse, we're the only two more or less independent 2-in-1 providers. All the other providers are housed at United Way organizations. We have a very sophisticated telephone system. We can't be tied down to, we need to be able to answer as many calls as come to us. So, you know, many phone systems, you can only have a limited number of lines available to take calls. Ours is virtually unlimited. Excuse me. So it doesn't matter, and what happened back in 2010, in July of 2010, there was massive flooding in the city of Milwaukee. There was raw sewage backing up into people's basements after a very, very heavy rainstorm. And about 20,000 dwellings were affected by that. So we were asked by Milwaukee County Emergency Management to take flood damage reports from households that had damage. And a typical day for us is, back then, was between 400 and 600 calls a day. That was a normal, typical day for us. When the word went out that we were collecting flood damage reports, we had at one point 1,500 calls waiting to be answered. So our system is like an accordion. It can expand and contract depending on how many calls are coming in. Very quickly, we were able to get help from other 2-in-1 providers in the US. We had two 2-in-1 providers in New Jersey, 4 in Indiana, plus the other 2-in-1 providers in the state helped us with taking that very heavy call volume during that period. So we all did that within about 2-3 hours. We were able to really kind of summon all of that assistance very quickly. Our staff, most of them can work from home. And that's really important because everybody working on third shift works from home. Holidays, if they choose to work from home, we let them do that. When the weather is really bad, like when we had the polar vortex this past winter, 6 out of an 8-day period, nobody was at the office. Everybody did their work right from home. So we didn't have to have them risk traveling and their car breaking down and people taking the bus. It just didn't make sense for that to happen. And also when we are in flu season, if people choose to avoid being around people that might be ill, they can do that too. We have an emergency backup generator as well, so if the power does go out, we can keep doing our work. So this is the call volume through the end of September, the number of calls from each of the 9 counties that you see there that are in our service area. So I mentioned Milwaukee and Racine County. Waukesha is number 3. We take a lot of mental health related calls from Waukesha County, but that's because of a special thing that I'll tell you a little bit more about later. But I think what's really important for you to know is that most of the calls that we get from every county are very much the same. So it's a lot of basic needs issues. So it's food, it's shelter, housing crisis, those sorts of things. So it really doesn't matter what county they're calling from. For the most part, the needs and the strains that people are facing are very similar. And I'll talk a little bit more about that in a few minutes. These are our answering times. So we're a call center and people are always curious, well, how long does it take to get through to you people? we get that one. And it's really important that people get through as quickly as possible. So we try to keep it in the 2 to 3 minute range. We've had a couple of blips in the last 12 months. End of January, especially in February, it was the polar vortex and a lot of calls that we were taking related to people's furnaces that weren't working or they needed shelter and other needs pretty much related to the very cold weather. And those calls ended up taking a lot longer than a typical call. So hence our wait times went up. And then in this past month, September, our wait time went way up. We've been doing a lot of retraining of staff on certain topics. And we made some changes in the database that they're using to document the calls. So we had to sacrifice our wait time in order to make sure everybody is being trained. We can't just close and train everybody. We have to train them in pods, and take a few people off the phones and do the best we can. It's just part of the deal, when we're doing this kind of work and we're working with really complex issues that these sorts of things happen. So besides the call taking, the other important function that we do at 211 is maintain information on all the different service providers in our 9-county region. So nobody else really does this sort of work. You'll see and you might find booklets with resources or lists. There might be some websites where you can find a limited number of resources on a particular topic. But our responsibility is to maintain information on a comprehensive basis. So everything you can think of related to basic needs, healthcare, mental health, substance abuse, but that would also include like day camps and parenting classes and senior centers and just about everything you can think of, meal sites.
Have you ever denied any one of these services?
I'm sorry?
Have you ever denied anyone of these services? Like, can you not reach their needs?
Yes.
Oh.
And I'll talk a little bit more about that.
Good question.
Another really good question. So, again, what's really important about our resource database is that we have a criteria for who we put or who we do not put in our database. So we screen organizations to make sure that they are not discriminating against anyone in the services that they provide. We have some faith-based organizations that require that in order to receive services, the person has to participate in a faith service, and there's a few providers that give out free diapers where you have to read some materials before you receive the service. That's okay as long as the person that's going there knows that's going to happen before they get there. So we will list that in our database. Make sure we have it in bold letters. This hoop has to be jumped through before you receive service. That's okay as long as the provider is upfront about all of that. But if you were to give a referral somewhere, and let's say it's a free meal, and all of a sudden you have to sit down and participate in something before you get the meal, and we didn't know about that, that would be a problem. We would not allow that to happen. Or they discriminate or have shown that their philosophy is that they don't include everybody. That would be a problem. Or that we've had this happen where we get complaints. People will tell us if we refer them somewhere, and if they feel like they haven't been treated fairly or the service was not good, we will investigate it. And we have taken organizations out of our database where we have substantiated that complaint. So we will do that too. But I think the important part is that nobody else really does that sort of work. So it's really important. It's very valuable for people getting information to know that we've asked them a few questions to make sure that the services that they provide are exactly as they say they are, and that when they get there, they'll be treated decently. So, when we do our work, so somebody calls us, and what you see here in this kind of outline is essentially kind of a problem-solving model. And So people call us, and some people are really straightforward, and they know exactly what they need, and it's really easy for us to find a resource for them. So somebody calls us and say, I'm gonna be out of food by tomorrow, and I need a food pantry. And so we look in our database and we find out the nearest food pantry where they can go, and we give them that information. And we might ask, is there something else going on, or what's led up to you needing emergency food today? I just had, I had to buy my kid a new coat for school, and it kind of just ate into our cash for the month. And I'm getting paid on Friday, and we're gonna be good to go after that. It just is one of those episodic things, happens a couple times a year. But for the most part, people are doing okay. We might ask that same question of somebody, and they say, I just lost my job, and I got fired because I didn't pass a drug screen, and and they let me go, and I lost my insurance, and I haven't been feeling very good for quite a while. And all of a sudden, just because they called for food, there's a lot of other things going on that precipitated that. So we might start asking, do you want us to kind of talk a little bit more about that? Can we maybe find you might have some resources where you can get more help with these other things that you're talking about? And for some people, it might be, it's good to know, I'll call you back maybe tomorrow. I just really gotta get food in the house for their kids right now, and I don't have much time to talk, but, we provided that offering, that we're there to talk more about all the other things that are going on. But we could get into it, and we could start talking about, I need substance abuse treatment. I've been drinking really heavily for all my life, and I knew this was gonna happen. I knew I was gonna lose my job, and now I don't know what to do. And so that's where we kind of get into doing a deeper assessment of the situation and providing them with some encouragement that, help is out there. Let's look at our database and see what may be available to you. So it's not, for those situations, it's not, here's a list of numbers, good luck. The reality is anything related to healthcare, anything related to mental health treatment and substance abuse treatment is that services are very limited. There's just not a lot of availability. If a person doesn't have insurance or doesn't have an income, it becomes even more difficult to receive help. And even if you do have insurance or you have an ability to pay, there may be barriers when you call someplace. They may not be accepting new patients. If you are of a certain gender and you want to only work with somebody that has a similar gender to you, and that person's not available, that might be a barrier. There's some place right down the block from where you live, but that person says, I don't want to be seen walking in there. I got neighbors that talk, and that's the last thing I need is more of that stuff. So we got to be really respectful of a person's values, their ability to pay for the service. Is it culturally appropriate for them and their values? We have to be very mindful of all of those things before we give a referral. So knowing that somebody's gonna potentially face all these barriers, the best thing we can do is to try to call ahead to these, we might find 10 different places, but we'll kind of start going down the list and calling ahead on behalf of that person and saying, are you seeing new patients? No, we're not. Okay, thank you. And we'll kind of go through all those different tripwires till we make a pretty good match. And we got this person still on the other line, and we're calling ahead. And when we do make that match, where you do find a resource or a provider that sounds like it's a good match, we're going to directly transfer that caller over to that provider so that they can then talk and make arrangements to get help.
So someone calls you doing that kind of work right on the spot, so they don't meet with like an interventionist or you're doing it right?
There's a part of our agency that does that with, substance abuse issues, but everything is done over the phone that we do. And, the next step might be that they then talk face to face with somebody.
But not from 211.
No.
To where they refer them to.
Correct. And we have, trained and licensed AODA specialists available to us. So, if we get something that's a little bit more complicated, and they need a deeper assessment, we will talk with somebody and give them a little bit more space to talk out some options. But no, they don't, traveling can be a real problem, so we try to do as much as we can over the phone, yeah. Yes?
So if somebody is, and they admit that they are doing drugs and they have their child or something,
Yeah.
and you know, like, it's a dangerous situation, do you still respect their values, or do you take it into your hands to call the police?
If we're being presented where a kid is directly in danger, you
Yes.
know, if we've got somebody that is intoxicated and we hear a kid crying in the background, we're gonna call 911.
Okay.
You know, we're in a real gray area because we're not mandated reporters.
And the person can't, like, report it, they would have to hear it from that person?
You have to observe it,
Okay.
yeah. And for us, the best we can do with observing is listening and hearing and asking questions. And it does happen that we get somebody that is decompensating on the phone when we're talking to them, and we can hear a kid, we're gonna call 911, we're not gonna do that. And the danger is that, you know, it may never happen, but you could be calling and say, you know, I'm calling on behalf of my sister, and she's got a kid in the house, and she's drinking a lot and all that, and the police show up, and the sister's going, she does it all the time, you know, there's nothing wrong. So we're kind of in a delicate place with some of that too. Yeah. Does that answer your question?
Yeah, so like you can't, if you know somebody's in a situation that is a danger to a child,
Yeah.
or, and if you report it, you can't really do much about it.
We can report it, absolutely, yeah, and we've done that, we've called CPS, and
Okay.
we do that, you know, we aren't mandated to report it, but we act like we're mandated to report it,
Alright.
yeah.
Yep, that
So,
answers.
you know, but when I talk about what we do here in Waukesha a little bit later, I'll tell you a little bit more about CPS type situations and how we handle those.
Alright, thank you.
Sure. So, how many of you know about the social determinants of health? Has that ever come across with anything that you faced? Okay. Do you know about Maslow's hierarchy of needs?
Yeah.
Okay. That one we got in high school, so that should be out there. So these are kind of cousins. These concepts are, think of them as cousins. And social determinants of health is a little bit more global and takes into account a lot of different things, more at a community level or a societal level. But having certain things not there starts to affect individuals, households, neighborhoods, communities. And so if you think about Maslow and you think further up the pyramid, the further up the pyramid you go, the more you get well off you're doing. You know, your basic needs are met. You don't have to worry or stress about maintaining your housing or having food and clothing for your kids and yourself, and you're able to work on your education. You can just simply relax and read a book because you enjoy reading. And if you believe Maslow, you can only really do those things if those things further underneath that pyramid are taken care of. They're not stressful things. So for an individual, if you kind of look at these things, not having something available can cause some stress. It might be a little stress, or it might be a whole lot of stress, or the effects could be really minimal, the effects could be really, really huge. So when you think about, an urban area, and you don't have a car, you got 3 kids, and your options for transportation are very limited, but you want your kids to be outside, you live in an apartment building, but you want your kids to be outside and enjoy the fresh air and run around. And it's not there where you're living. So having access to a playground that you can go to and that you feel safe going to, that the equipment there is clean and safe for the kids, that little social determinant is being met, it's being taken care of. You have access to it, the kids are getting out, because they're exercising and doing other things, they're gonna be healthier. So all those things are in place. Not having that available erodes a little bit of that. Think about kids, they need a variety of experiences in their lives. They need to go to the library, they need to, be around kids their own age and, just experience as many different things as they can. And just not having that playground available to them takes away a little slice of what makes this kid a whole person, when you're feeling left out or anything, it does affect somebody. When we talk about and kind of matching, overlaying Maslow with the social determinants of health, I could think about somebody that has a chronic illness, so that could be asthma, diabetes, or a chronic heart disorder. And most of the time, people can go through their lives, and as long as they're taking their medications, they're watching their diets, they're exercising, and all those sorts of things, people can live with these chronic conditions and do quite well and thrive. They stay employed, they take care of their families, they take care of themselves, and they meet all their needs, only because it's being managed and taken care of. For somebody that has, let's say, asthma, and they need an inhaler, or they need to take some sort of medication, or diabetes, you need medication or insulin or something like that to manage your diabetes. And you're in a situation where I work in a low-paying job, and I got 2 kids, and most often I'm able to pay my rent, pay the utilities. I might have to go to a food pantry every now and then, but my kids are being fed. And all of a sudden, your child needs some new shoes and a warm coat for winter. And I don't have any savings, but I have this cash that I budget out to take care of myself between paychecks. Or I have to get my car repaired, or something like that. All of a sudden, you have a major a change in your finances. Your available cash is less than you thought. These medications that you take, there's a copay every time you fill it. It's $20 or $50 or something like that. A person in that situation is going to prioritize things. Is my kid going to walk around in shoes that aren't appropriate for them? Or am I going to take care of my medication? Am I going to repair the car so I can get to work, so I can keep earning a living? Or am I going to pay the copay on my medication? Some people make choices, and this is a real basic situation, but they may make the choice, I'm only going to take half of my pill for the next few weeks to get through, because I can't afford to get it refilled. But I'll kind of carry over for a couple, 3 weeks at half of what I usually take. So with a lot of medications and with a lot of these situations, a person's health is very delicate. If they aren't getting the medication they need on a consistent basis, the way it was prescribed, it could be that they may have problems with diabetes, especially. A person can have problems with symptoms related to their diabetes, and some of them can be really, really serious. And they may end up in the emergency room, and all of a sudden, because they aren't taking their medications on a regular basis, now they are incurring a big health bill. I might not be able to work for a week or whatever. in everything, the house of cards just kind of starts to crumble, only because they had to make a choice between one thing and another. So a lot of people are living paycheck to paycheck. A lot of people, especially I was a student for many years, it freaks you out when something happens and you know, you have to worry about that. And not everybody has a family member to lean on or has a savings account or all those things. Everything can be really delicate. So that's why with the social determinants of health, when things aren't being taken care of, it can really start to impact things related to prevention. Health prevention is a really good example that I was describing before. Not having that medication, the manageable becomes unmanageable. Ongoing care can be compromised. A chronic illness that's usually manageable and you can take care of things might become more acute or recurrent. And all those things start to erode the stability for that person and for that household. So now you're in a situation where health, parenting, I'm short-tempered with my partner, we're not getting along as well. If you're an employer and you got employees that aren't showing up for work, your business is gonna suffer. So just one person struggling has a ripple effect across a lot of different areas. You know, and you add that up with a lot of people struggling and a lot of people not able to maintain the way they would like to. It just creates some instability in a community. So one person, yeah, you know, you can look at that, but you got a lot of people and it starts to affect a lot of people, a lot of different spheres, neighborhoods, communities at large, classes of people that aren't being treated fairly or don't have access to resources in the same way others do. It does matter. And that's why we pay a lot of attention to looking at communities and seeing if resources are fully available to everyone. So that's what, getting back to your question about unmet needs. That's what we keep track of, and we do have situations where, and especially it happens with housing and being able to pay rent and those sorts of things where resources for that just simply don't exist.
Mm-hmm.
Or they're very, very limited, or there are qualifications that keep a lot of people from accessing it. So through the W-2 system, for instance, there's something called the Emergency Assistance Grant, which is a one-time payment that a household can get to pay back rent. But there isn't a similar program for single adults or households without a kid. So that's a major gap. There really isn't a resource that we are aware of that is reliable, that would help a person pay their rent if they weren't within that very specific class of people. So that's the kind of data that we collect. And then we pass that information on to policymakers, to funders like United Way and community foundations, organizations that might be able to help. So we collect that, pass that along, and it does shape policy. It does shape how services are delivered. There was a really good example from a few years ago in Milwaukee where we were having a really hard time finding a food pantry for people living kind of up in the northwestern part of the county. That part of Milwaukee County saw like a near doubling in the number of households living in poverty within a relatively short period of time. And the services did not go along with this increase in the number of people living in poverty. And we were really struggling trying to find a food pantry for households that didn't have transportation that they could get to. So we worked with the Hunger Task Force. We had all this really good information on unmet needs. We could not find a food pantry for people. We took that to the Hunger Task Force, and what they did is they established a new food pantry at a church, and they expanded the capacity for another food pantry so they could be open an extra day. So that's one illustration of where our data made a change. So that was an easy one to solve. The whole rent problem is really difficult to solve. And the other thing is, even with all that good data, it takes time to really solve certain situations. And when we do talk with people that are, where we can't help them, we're gonna start working outside the box. We go, sometimes we have to be a reality check and say, there just isn't anything available. What other sorts of options can you think of? With things like not being able to pay rent on a regular basis, that's where we have to start talking about, maybe you need to change your living situation. You know, it doesn't sound easy, but, you know, if this is gonna keep happening every other month that you can't pay your rent, maybe you need to think about moving in with somebody or finding a place that you can afford. And those are really hard conversations to have with people, but we try not to leave people hanging. And at least if they say, no, I don't wanna do that, hopefully it gets people to thinking about other options. So those are hard conversations, and they happen every single day, several times a day, where we can't help somebody. Do you have a question?
Well, I was just gonna say, did you guys like help with, cause they have low income housing? Did you guys help with that?
Yes.
That's pretty, awesome, cause a lot of people don't have credit or have bad credit, and it's really hard to find a place.
Right. Yeah, there's a real lack of affordable housing everywhere. And in Waukesha County, there's a real big gap, because there's a lot of housing available for people that are making a lot of money. It's all over the place, and the number of apartments or homes available for people that are a little bit lower income are very limited. And there is subsidized rental housing for people at a certain income level, and they often have kids or they're elderly or disabled. It's available for some people, but usually there's a waiting list, or many places aren't even accepting applications. So there's still a big unmet need in that whole area.
Yeah, and I feel like especially when you have a baby or something, I think you might get in there a little faster or something. I don't know.
It depends, you know,
Yeah.
it really depends on what's available. Yeah. But at least passing along the information, and this happens a lot in Milwaukee, where the housing authority will open up applications for like a week or something like that. And we always encourage people that are looking for housing, get on as many lists as you can. You know, you never know, because they'll start calling 20 people on the list, and they call the first 15 and there's no answer, and if you're 16, you might be the one that gets it. So we coach people on how to access and work within the system as best as we know it anyway. So what you see here, these are the call categories through the end of August. And with the exception of the mental health calls, it kind of looks like an upside down Maslow's hierarchy of needs. So you see a lot of basic needs. So shelter, food, housing, clothing, those are all basic needs things. Those tend to be very high in our list. We struggle a lot with shelter and housing because of the lack of availability, and because there are certain qualifications to access those services that many people can't get into, or because there just isn't any availability. With household goods, we struggle with people that are looking for a refrigerator or a stove or a mattress. Those are really hard things to come by, and that's especially critical for families with kids. You need a refrigerator that works, you need a stove that's safe, and those are really hard to come by for free. You know, they're just not out there, and trying to buy something like that new or even used can just be too much. So there's certain things that we struggle with. It's not a lot, but it's enough that you think about how many people, you know, if we get 25 calls a month for, you know, parents that need a new refrigerator, that's 25 families that don't have a refrigerator in our community. And so those sorts of things are, even though it's not a big call volume, it can be really important to be aware of and know about. So, I think I told you our history goes back to 1960 or so when our organization started. We were dealing with people that needed help with substance abuse issues. So back then it was alcoholism and not so much other drugs, but it was there. And like I described earlier, things have changed quite a bit, and most recently over the last, I want to say 5 to 7 years, the heroin and opiate problem has really been difficult to deal with in all of our communities. Because of that, the state asked us to apply for a grant to assist people that needed help with their addictions, especially as it related to the heroin and opiate problem. So right now we are part of what's called the Wisconsin Addiction Recovery Helpline, powered by 211. So there's a special toll-free number that people can call, and we went through the process of updating all of the substance abuse resources in the entire state. So we did a complete screening of everybody that we already had in the database, and then we looked even deeper to see if there's organizations that we missed. So we made sure that our entire database was populated with all of these different providers. And then because of Impact's history of doing this sort of work, we trained all of the other call centers in the state, all their call takers, on how to best work with somebody that's struggling with a substance abuse issue. So we did that over the course of a few months, and it was about a year ago that we started the helpline itself. I did a report this morning, and just from October 1st to yesterday, we had about 70 calls on that issue. Alcohol is still the #1 problem that we deal with, but heroin and opiate issues are number 2. And in this region as well, the other things that we see here that are a little bit unique compared to other parts of the state is cocaine. We still have a lot of cocaine coming into this region. Up in the northern part of the state, it's methamphetamine. That's kind of the number 2 or 3 drug abuse of concern up in the rural northern parts of the state. So it varies on where drugs are coming into our community. For the last, I want to say 3 or 4 years, I've been a part of the Waukesha County Heroin and Other Opiate Task Force. So the task force is made up of hospitals and volunteer groups like Alcoholics Anonymous and other types of groups, other private health providers, many other different groups. Law enforcement is a part of it. And one of the projects that I worked on, and I'm part of the treatment pillar of this task force, and the project that I helped with was surveying all of the medication-assisted treatment providers in Waukesha County. So medication-assisted treatment providers are those that are prescribing drugs like methadone. Have you ever heard of? I'm sure you've heard of methadone. Another one is Suboxone, another big one that's out there. Vivitrol for some. So these are all medications that help. The idea there is you wean off of your dependence on an opiate with these medications. These medications kind of take the place in your brain chemistry of the good things that you're getting out of the heroin or the opiate. But you're able to function, and over time, those sorts of medications are prescribed at a lower and lower level until a person gets to the point where they don't need that anymore. But to go through that process, it's not just take the medication. You need counseling, support, and other sorts of treatment so that you can be successful, so that you can live a different type of life other than one where you're looking for drugs all the time, or where you're feeling like you need these, you need other sorts of supports, and for some people, it means being involved with a different group of people that aren't behaving or acting the way you were when you were doing that. So it's not a one-off thing. So we surveyed all of these providers to see if they were employing best practices. Along with the medication, we wanted to make sure that they were providing those other sort of supportive services like counseling or access to support groups, all those sorts of things. So it's not just one thing, we wanted those that are doing everything. So there were about 30 or so, and I'll get to you, there were about 30 providers that we surveyed, and only 13 of them met the criteria that fit within the best practices. So our task there is to work with those others that didn't meet the best practices and try to provide them with the supports that they could use in order to deliver services at that best practice level. Yes.
So because methadone and Suboxone can be addicting, is it because of like, I don't know, but like naltrexone stops cravings? Why wouldn't that be like kind of pushed more? Cause it's not addicting, and I know if like you take too much of a drug to feel something, you can die. But I feel like naltrexone would be like a better alternative because it's not addicting.
Yeah.
But like, is that the only reason why? Cause you can die.
I'm not qualified to answer that.
Oh, okay.
Yeah, I think the important thing to know about these medications that are being prescribed is that they're controlled and very tightly controlled, as opposed to street drugs, which are all over the place. So these controlled medications reduce, from what I know, what I understand, is they reduce the craving that a person needs for the opiate. It takes away that need.
Right.
Yeah.
Like you can't use if you're on Suboxone. Like if you
Right,
take
you still
Suboxone,
get
you
that
can't like
effect
go and
though.
get dope and it won't work. It like basically turns off like your opiate receptors.
Yeah.
Yeah.
Like in your head, which is why the cravings and the withdrawal stops.
Yeah, but you still
But
get.
you can still take high off Suboxone or methadone really at a certain dosage.
You should get somebody in to talk about that. I've been around all these people, I know all that
Oh, I
stuff,
talked
but
about it.
I couldn't repeat it all myself.
Yeah.
I think what's really important to know though is that, a lot of people are involved in trying to solve this problem. And, law enforcement is even changing on how they're working with people that are coming into into the whole correction system, and there's really been a shift with trying to give people help and not just really put the hammer down on them, because people go into prison and they don't get the treatment there that they need, and that doesn't really solve the problem, because they come out and they're kind of back at square one again. So there's different things going on that hopefully over time will be effective. Talk about that. So we deal with a lot of different crisis situations. So this could include a young mom just came home from the hospital with her new baby, and she's a little bit isolated. Family doesn't quite like her a whole lot because of everything that happened, because they told her not to hook up with that guy. She didn't listen, and now look what happened to you. So we hear, you get people that are in that situation. Working a part-time job, probably getting, Badger care, or, getting Medicaid and food stamps and things like that. But, the one thing mom needs today is some diapers. She doesn't have any cash. I can't go to my family because they don't even talk to me. And we could hear the baby, she's with the baby, you can hear the baby. For her, that's a real crisis situation. She's not doing anything wrong. She's not harming this child. She's doing the best she can under this really difficult circumstance. So that's a crisis situation. And so we're gonna find a place where she can get those diapers. we try to ask a second question, you know, what else is going on? How else will we be able to help you with your situation? And for her, for one mom, it might be, I just need the information for the diapers. I got this friend I work with that said she would drive me there, but she's gotta get to work at this time, so I don't have any more time to talk, but I'll call you back. And that's fine. We might offer, is it okay if we call you back, when you have more time? So we try to keep that door open to her. So it could be that that problem was solved, she's gonna get paid in a few days, and this is a short-term situation. Otherwise she's doing reasonably well. Not great, but doing reasonably well. But we get a lot of other crisis situations related to mental health issues. Child abuse and neglect, elder dependent adult abuse and neglect, DV, people that have been sexually assaulted, people that are experiencing a health emergency. We get a lot of people calling that are afraid to call 911 themselves, and they're in a really distressing situation. And some people just don't realize they're in a really, really severe situation. There are some people that live in crisis situations all the time. It's almost like a normalized state of being for some people. And we can hear things being described to us that sound really scary. And for them, it's just, you know, not a whole lot different than the last time it happened, and I made it through that time. So, and we've talked to people that, you know, they're having trouble breathing. You know, there's things going on with them physically that should be very concerning. But that's kind of how they live their lives. And so we sometimes recognize a crisis, sometimes even when that person doesn't realize there's a crisis going on. As often as we're able to, we do have caller ID. So we have that with people that we talk to people that are suicidal, and we're glad they called, and we try to get as much information as we can from them. We try to find out, you know, do you have a plan? Do you have access to the means to harm yourself? You know, some people have weapons, some people have a bottle full of pills, a lot of different things that they may have, and that they're ready to use them. So we try to get as much information as we can from them, try to get their name, hopefully we can get an address, build some trust with them, knowing that help is available for you, and I'm here to try to get you some help. And some people respond really positively to that, and they give us their name, they give us their address, and then we call 911 dispatch centers, and we do that intervention. Sometimes that's not possible. Sometimes we've talked to people that have already taken the bottle full of pills, and as we're talking to them, they're fading away from us. We do the best we can with caller ID. Sometimes 911 dispatch centers have had previous encounters with that phone number that we give them, so sometimes they can trace it back to that person and know who they are. We talk to people that are in domestic violence situations, and sometimes we get information from them by asking yes/no questions. So do you live in Milwaukee? Yes. Do you live on the north side? No. Do you live on the south side? Yes. Do you live north? This has happened a few times, where we just keep asking questions until we narrow down where they live. And then their person is sitting there, and all they're hearing is somebody saying yes and no on the phone. They're not conversing. So we have tricks to getting information from people too that we've employed over the years as well. So in all these situations that you can think of, the first thing we're always going to be doing is assessing for their safety. So it doesn't matter what the scenario is, if it sounds like their safety or the safety of others around them is in jeopardy, we're going to intervene right away. In other situations, we're going to be transferring that person over to a professional that specializes in any one of these areas that you see here. So we may make a transfer over to a mental health professional that can then take over that call and help work, and then work with that person. for Child Protective Service calls, we are working, and I'll talk a little bit more about this later, but we work directly with Waukesha County Department of Health and Human Services and doing all their initial intake for those situations. And we have a protocol for how we handle those. And same thing with elder and dependent adult abuse and neglect. So real quickly, I'll talk about some specialized services that we do related to crisis mental health issues. So we started taking all of the Milwaukee County behavioral health crisis calls a little over about a year and a half ago. So all the calls that were previously being taken by them are now handled by us. So we're doing a basic triage for folks that are experiencing a mental health crisis. And from there then, we're determining whether an intervention is needed or they need to be transferred over to a specialist at Milwaukee County Behavioral Health. So that's our role there. Many people that are calling us just need some supportive listening. They just need somebody to talk to for a few minutes every day, and that's perfectly okay. If that helps them manage their symptoms and get through the day and not need a crisis worker or tying up a worker somewhere for something that isn't a crisis, that's an important job that we have for them. And we've been doing the same thing with Waukesha County since 2013. With Milwaukee County, we do it 24/7. With Waukesha County, it's overnights and weekends and holidays. And then for the adult and child protective service calls, again, this is overnights and weekends, holidays. We're taking that initial call, and from there, we're assessing for safety, and then we're directly transferring them over to one of those appropriate workers. So we're not taking the report, but we're just making sure that the person that's filing the report is talking directly to somebody. About half the calls that we get are from mandated reporters, so these are often school officials, hospitals, hospital personnel, and also law enforcement. But we do get family members, neighbors, other observers that are seeing something going on that they're not comfortable with that are contacting us. But the important thing is that we're always intervening to make sure that when a kid is in danger, that we're doing that first. So I'm going to skip ahead just a little bit. The only thing I'll say here is we do all of the intake for individuals and households that are in need of emergency shelter, all pass through us first. So we do an assessment for people that are homeless or are facing a housing emergency. And then we do either placement or referral directly into the shelter system. So our job is at the end of the day that we fill up every available shelter bed. And it's done in a way that everybody is essentially assessed in the same way. So that a person that isn't as vulnerable doesn't get into the shelter beds ahead of somebody that is more vulnerable. So that's our job, is to do the assessment and weigh all the different factors that are going on in a person's life to make sure that they're getting the most appropriate referral. So every county has a process similar to this, but we do it all for Milwaukee County. In Waukesha County, it's pretty much the same thing. There are just very fewer shelter beds and housing beds available. And I guess the other really